The anterior drawer test of the shoulder could be used for suspected shoulder instability, specifically anterior instability. Have the patient lying on their back supine. Bring them to about 80 to 120 degrees of abduction, about 20 degrees of flexion, and slight external rotation up to about 30 degrees. Instruct the patient to relax. Your mobilizing hand is going to be in the patient's axilla, and the stabilizing hand is going to come over the coracoid and the spine of the scapula. Place your middle and index finger over the spine and your thumb over the coracoid to hold the scapula still. Then apply an anterior force, pulling the humerus forward to try to see if you can reproduce any apprehension on the patient's part. They may oftentimes say, "Don't do that," or "That bothers me," or you might get a bit of a click, clunk, excessive anterior mobility, or motion. Any of those would be indicative of a positive test. The apprehension or crane test can be used if you suspect anterior shoulder instability. Have the patient about 90 degrees of abduction, then begin to externally rotate them as you are watching your patient, because oftentimes you may see signs of apprehension that they do not like this position. They will either begin to pull against you or say, "Please don't do that," which is considered a positive test. From the apprehension test, you can move them into the relocation test, which is also used to assess for anterior shoulder instability. You will take your patient out of external rotation a bit and place your hand over the head of the humerus and give a posterior translation stress to stabilize the humerus. Essentially, you are relocating the head of the humerus out of the anterior displaced position, and this should cause the patient to lose some of their apprehension and pain. Then see if you can move the patient further into external rotation if they will allow it or if it's not painful. A positive relocation test is further motion into external rotation prior to pain or apprehension returning. The last part of this series of tests is called the surprise test. You now take your hand off from the relocation position and see if you get a clunk or dislocation. The test is positive if you return the pain or apprehension of the patient. Clinically, this is not recommended to perform the surprise portion. You can injure your patient. A special test that can be used for a suspected shoulder instability is called a load and shift test. Instruct the patient to sit up, relaxed with good posture. There should be no back support. Take your stabilizing hand and basically go on either side of the acromion. Place your mobilizing hand on the anterior and posterior aspects of the head of the humerus while stabilizing. Then shift your mobilizing hand anteriorly to see if you get a clunk or click. This would be positive for anterior instability. Then you could also go posteriorly to assess for posterior instability as well. If you get a clunk or click, that would be positive for posterior instability. For both, you are looking for reproduction of symptoms, a clunk, or excessive motion to indicate a positive test. If instability is noted in both directions, this person may be positive for multidirectional instability. A clinical test that could be performed if you suspect a posterior shoulder instability is called a jerk test. Bring the patient to a 90 degrees of flexion, some internal rotation, and then stabilize the scapular area. Then apply a force straight through the arm to axially load the humerus proximally while moving the upper extremity into horizontal adduction. If this person had a posterior instability, the head of the humerus will kind of sublux off the glenoid and result in a clunk or reproduction of the patient's pain or symptoms as well, indicating a positive test. The test could also be indicative of a posterior inferior labral tear, but this doesn't really mean anything clinically because you will still treat it as an instability issue. A test that you could use if you suspect a posterior shoulder instability is a posterior apprehension test. Have the person lying on their back. It can also be performed in sitting, but it is more difficult to get people to relax that way. Bring the arm to about 90 degrees in the plane of the scapula, and then you're going to create a combination motion of internal rotation as you horizontally adduct the arm across to the opposite shoulder and apply posterior force through the humerus. A positive test would be if the patient is apprehensive and asks you to stop doing the motion, or you feel a clunk as the head of the humerus subluxes posteriorly off the glenoid. A posterior drawer test can be used if you suspect a posterior shoulder instability. Have the patient lying supine on their back, place the shoulder in about 80 to 120 degrees of abduction and about 20 degrees of flexion. Your hand will come up into their axilla and your stabilizing hand over the coracoid and the spine of the scapula. Your thumb will be just lateral to the coracoid over the humeral head. From this position, provide a posterior lateral force to the head of the humerus. A positive response would be apprehension, a clunk or click, or reproduction of the patient's pain. A test for multidirectional or inferior shoulder instability is called a sulcus test. Instruct the patient to be very relaxed. Find the tip of the acromion and you're resting basically in that subacromial space. Then hold on to the distal end of the humerus and provide a downward traction. Often what you will see is a sulcus, which is the head of the humerus dropping down. You might also feel a bit of a clunk. A positive sulcus test is if the patient's symptoms come on with an inferior pull of the arm or the humeral head is displaced 2 or more centimeters from the acromion. This is also highly indicative of some shoulder laxity. A test used if you suspect shoulder impingement is a Hawkins-Kennedy test. Have the patient in 90 degrees of flexion and then push them into some internal rotation. You can add a bit of horizontal adduction as well. The test is positive if it reproduces complaints of the patient's impingement type pain. However, this test is painful in many people. If it is not painful, you can more confidently say it is negative for shoulder impingement, but if it is painful, it is not very helpful because the test could be painful in anyone with any shoulder issue. You would also only do this one time. I was just demonstrating it multiple times for the purpose of the video. A good diagnostic clinical test for the shoulder is the Zaslav test or the resisted internal rotation test. Have the patient come into about 90 degrees of abduction and about 80 degrees of external rotation. From this position, instruct the patient to not let you move them and perform isometric resistance internal rotation. Now take the person into internal rotation and perform isometric resistance to external rotation. Instruct the patient, don't let me move you. The way to judge this test is to see in which motion the patient is significantly weaker in. If the patient is significantly weaker with internal rotation versus external rotation, then you would want to look for possible some sort of intra-articular derangement, maybe a labral tear or something else intra-articular. If the patient is much weaker with external rotation versus internal rotation, then you would think more that the test is positive for rotator cuff pathology. A test used for possible shoulder impingement is the near impingement test. The patient will be seated. Bring the patient's arm up into as close to 180 degrees abduction as you can with maximum internal rotation. This will jam the greater tuberosity on the acromion. You are looking for any pinching or patient's reproduction of pain right in the subacromial region. This would indicate a positive test for near impingement sign if the patient's complaints are reproduced with the internal rotation. You could repeat this test with the same motion except now maximum external rotation. If the patient had complaints of pain, especially near the AC joint with the external rotation, that implicates a possible AC joint arthrology. Another test used for possible shoulder impingement that is quite similar to the near test but is performed supine is called the supine impingement test. Start with bringing the patient's arm into external rotation. Then passively take the upper extremity into end range abduction and elevation while maintaining the arm supinated and externally rotated. You are almost bringing them across into adduction. From this position, internally rotate the arm, and if you're going into internal rotation, significantly increases the patient's pain. That would be considered a positive test for possible impingement and or rotator cuff pathology. The posterior internal impingement test is another test that can be used if you suspect shoulder impingement. The patient you should use this is for typically an overhead athlete that will be complaining of pain, specifically when they're way back in kind of the late cock-up phase, right before they're ready to release, and when asked where they feel their pain, they will point to the very posterior aspect of the shoulder. Their complaint is typically a posterior pinch, so this particular test is designed to reproduce that. Have the patient lying supine and bring their arm between 90 to 110 degrees of abduction and ideally drop them down into about 10 to 15 degrees of shoulder extension. Then maximally take that person into external rotation as far as they can go. A positive test would be reproduction of the posterior pinching, or some call it a kissing lesion type of pain deep in the posterior shoulder. The impingement feeling is a rotator cuff impinging against the posterior superior edge of the glenoid. A test used for suspected shoulder labral tear is the O'Brien test. The person will be standing. Have the patient about 90 degrees of flexion, maximally internally rotated, and horizontally adduct their arm across their body from that position. With the internal rotation, the patient's thumbs will be pointed downward. Then resist them from any further shoulder flexion, and the patient will typically complain of some pain. Then keep the patient in that same position except now in external rotation, and the thumb is pointed up, and apply the same resistance. A positive test for a labral tear would be if there's clicking, popping, or less pain when they have resistance with thumb up and external rotation versus with thumb down and internal rotation. Be specific with where the patient is reporting their pain or symptoms. If they complain of pain at the AC joint, that may be more indicative of an AC joint issue than a labral issue. A labral issue would be pain deep inside the shoulder. The biceps load test can be used if you suspect a labral tear. You can have the patient sitting or supine. For the biceps load 1 test, have the patient in supine and passively bring their arm out into about 90 degrees of abduction and max external rotation with the forearm supinated. The patient is then instructed to contract their biceps against your resistance. For the biceps load 2 test, have the patient supine again. This time you'll passively bring their arm up into about 120 degrees of abduction, max external rotation, and with the arm supinated. Then instruct the patient to hold their arm in this position and to not allow the therapist to straighten their elbow out. You will be resisting biceps in this position and seeking to reproduce any of the patient's complaints of deep shoulder pain or the complaints that would be considered a positive test. This would be a good test to pick up SLAP lesions. A test for a suspected shoulder labral issue is the anterior slide test. The patient can be standing or sitting. Have the patient rest their hand on their waist with their thumb pointing backward. With one hand stabilize at the clavicle and scapula, and with the other hand provide kind of a superior anterior force through the elbow. The patient will be instructed to resist this movement. So essentially the therapist will be pushing up and forward and the patient will be pushing down and back and resisting your motion. The test is considered positive if it reproduces the patient's anterior superior pain with or without a pop or click. The test has a questionable sensitivity and was designed to test the superior aspect of the labrum. A test used for a suspected labral tear and could be used for possible anterior instability at the shoulder is the Klunk test. The patient will be lying supine. Make a fist with your hand and place it just kind of at the posterior aspect of the patient's shoulder over the humeral head, and with the other arm grasp the humerus or elbow. Bring their arm into full abduction, at least 120 degrees of abduction, and external rotation, and try to almost drop the shoulder right back over your fist. With the hand that's grasping the elbow or humerus, push down towards the floor as the fisted hand is pushing upward. It's considered a positive test if you get a clunk, reproduction of complaints, or a grinding sensation is noted. This test has questionable sensitivity and isn't often favored by the patients. A test used to assess for possible posterior inferior labral lesion is the Kim test. The patient will be seated with their back supported but their scapula unsupported. Bring their upper extremity into 90 degrees of flexion. The therapist will provide support at the elbow and forearm while applying an axial compression along the line of the humerus. My hand should be above the elbow to give clean compression through the humerus and not elbow, but for better view my hand was placed a bit lower. The other hand will be providing a posterior inferior glide of the proximal humerus. It is considered a positive test if there is a sudden onset of posterior shoulder pain or a click. A test used for a suspected labral tear in the shoulder is a labral crank test. The test can be performed in either sitting or supine. The patient is in supine. You're going to bring their arm up between 100 to 160 degrees of scaption. Apply an axial load through the humerus. This will compress the head of the humerus against the glenoid. As you bring the person into internal and external rotation, you're kind of doing like the hip scour test we did for the hip. And that's what you're basically doing along the labrum at the shoulder. Ensure that you maintain the axial load as you move the person between internal and external rotation. A positive finding would be reproduction of the patient's deep shoulder pain with or without a click. A test used for suspected labral tear in an attempt to create the peel-back mechanism of a SLAP tear that typically involves the long head of the biceps is called the resisted external rotation supination test. Have the patient about 90 degrees of shoulder abduction, about 70 degrees of shoulder flexion, and to be neutral at the forearm. Provide resistance so the patient is going to be trying to maximally supinate into your resistance. At the same time, you are moving them into passive external rotation. A positive test would be reproduction of the patient's complaints, catching a click or pop that would be similar to the complaints that they had come in with. If you suspect AC joint pathology, a test you could use to try to implicate the AC joint is called the AC crossover test. This test can be done actively or passively. Have the patient's arm flexed to about 90 degrees and bring them into full horizontal adduction. You're trying to just shut down or impinge the AC joint. A positive test would be if the patient reports of pain at the AC joint. The test is not positive if it is painful at the shoulder. If you're looking for reproduction of their anterior complaint, things that might cue you to the AC joint being the problem is anterior complaints of pain, and a patient who maybe reports if they feel pain as they're bringing their arm into abduction, but get a little bit of impingement at the last bit of abduction, so somewhere between the 160 to 180 degrees of abduction arc of motion. A test used for the AC joint as a possible source of shoulder complaints is the AC shear test. Cup your hands around the deltoid. One hand will cup over the spine of the scapula and the other at the anterior deltoid around the middle part of the clavicle. From here, you are pushing both ways to create shear at the AC joint. A positive test would be reproduction of the patient's anterior complaints of pain. Another test used to assess the AC joint is called the Paxino sign. Put your thumb on the posterior labral aspect of the acromion and your index finger and middle finger over the middle part of the clavicle. Then pinch your fingers together to create shear. If you have a large patient and you have small hands, you can use the side of one hand and the other hand to apply your pushing. A positive test would be reproduction of those anterior complaints of pain. A test used for suspected rotator cuff problems at the infraspinatus and supraspinatus is the external rotation lag sign test. Passively bring the patient's arm in 20 degrees of elevation in the scapular plane, the elbow bent to 90 degrees, and then passively fully externally rotate the arm. Then advise the patient you're going to move your hand away and to hold their arm still in this position. If they cannot maintain this position and their arm begins to lag or drop down, that will be considered a positive test. The test has good clinometrics. If the test is positive, you can be pretty confident the patient has some rotator cuff pathology. Another test used for suspected rotator cuff pathology is the internal rotation lag sign, especially if you are suspecting subscapularis. Passively bring the patient into internal rotation with their hand behind their back and passively lift their arm away from their trunk. Instruct the patient to hold their hand there away from their body and that you will let go. If the patient can't hold this position and their hand falls back towards their body, that will be considered a positive test and more implicative of the subscapularis as the involved part of the rotator cuff. A test that you could use for suspected rotator cuff problems is the Hornblower sign. Some literature will say this test is more selective for teres minor. Bring the patient into about 90 degrees of scaption, the plane of the scapula, and into external rotation. Then instruct the patient to resist external rotation from this position. If the patient cannot externally rotate from this position, it reproduced their pain, or they were significantly weaker, that would be considered a positive test. A test used for suspected rotator cuff pathology, especially at subscapularis, is the belly press test. The patient can sit or stand with their elbow flexed to 90 degrees and instruct them to internally rotate from their shoulder and press into their belly. If the patient doesn't have good strength for internal rotation, they compensate by extending their whole shoulder back or flexing their wrist to make it appear as they are pushing into their belly, but is not coming from shoulder internal rotation. The test is positive if the patient is unable to keep pressure on their belly without extending their shoulder or flexing their wrist. You can also place your hand between the patient's hand and stomach, as I did, to get a better idea of how much pressure the patient can apply to their abdomen. A test used for suspected rotator cuff pathology is a drop arm test or arm dropping test or Codman test. This test does not really isolate out any specific muscles. It is important that you passively bring the patient into about 90 degrees of shoulder abduction and rest your hand over the spine of the scapula to prevent the patient from assisting in any kind of shoulder hiking. Instruct the patient to relax as you bring them up, and then let them know when you are going to slowly remove your hand and for them to hold it there. Then instruct them to slowly and controlledly lower their arm down to their side. Two things that would make this a positive test would be when you bring the patient up and remove your hand, they cannot hold it, or they can hold it but they are struggling as they begin to lower and then kind of collapse, indicating they cannot control the descent of their arm. Either of those would be considered a positive test. The drop or dropping sign is another test used for suspected rotator cuff pathology. Have the patient resting with their arm at their side. Then bring them into about 45 degrees of external rotation and have them resist that. You can also perform this test in 90 degrees of abduction and maximum external rotation to see if the patient can keep their arm in this position when you let go. It will be considered a positive test if they drop out of external rotation or can't maintain it. This test will be more specifically for an infraspinatus problem. A test that's used for a suspected bicipital tendon pathology or a superior labral tear is a Speets test. Have the patient come up into 90 degrees of flexion, full external rotation with the palm all the way up, full elbow extension, and full forearm supination. The therapist will provide manual resistance, pushing the patient down at the wrist while the patient is instructed to resist and push up into flexion. If someone has a bicipital tendon problem, this will be painful, and the patient will complain of some of their pain. Then turn the palm down and repeat the test. A positive test is indicated if it reproduces localized tenderness or pain in the bicipital groove, and if it feels better when the palm is down than when the palm is up. A test used for suspected pathology at the long head of the biceps is the Jurgensen's test. It's a good test, especially if you're concerned about the integrity of the transverse ligament or if the long head of the biceps is possibly subluxing as the patient moves. Rest your fingers over the long head of the biceps. This way you can tell if the long head of the biceps moves out of the bicipital groove and support the patient's elbow. Start the patient in a position with their forearm pronated and then instruct the patient to gradually be trying to turn their palm up and twist out at the same time while the therapist resists the patient moving into supination. A positive test could be a feeling of pain here, but mostly it would be a feeling of popping, clicking, or possibly subluxation of the long head of the biceps out of the groove. Shoulder mobilizations can be done from grades 1 through 4, with grades 1 to 2 being for pain modulation and grades 3 to 4 being used for stiffness and when you want to increase more range of motion. The first shoulder mobilization I will be demonstrating is the posterior glide. You would perform this mode when you want to improve flexion and internal rotation of the shoulder. The patient will be lying supine with their arm in the resting position and the arm slightly hanging off the edge of the table. Body mechanics are very far from ideal due to the use of a non-adjustable coffee table rather than a plinth for all the mobilization videos. The therapist will be between the arm and the trunk of the patient. The distal aspect of the arm is grasped and the other hand is placed anteriorly over the glenohumeral joint to provide the posterior mobilizing force. The head of the humerus will guide posteriorly. The next shoulder mobilization I will demonstrate is the inferior glide mode, which would be used to improve abduction or to correct a humeral positional fault if it's sitting superior. The patient will be lying supine and their arm in the loose pack position. The therapist supports the arm between the trunk and the elbow. One hand of the therapist is placed in the axilla, while the other hand is kept just below the acromion process. The force is applied on the head of the humerus in the inferior direction through the hand which is placed superiorly. The lateral glide mobilization is often used as a general humeral distraction technique and is often applied during the initial treatment to reduce pain and improve general mobility. The patient is in a supine lying position and the shoulder is in a resting position. The therapist's hand is placed in the axilla with the thumb distal to the joint margin anteriorly and fingers posteriorly. The other hand supports the lateral part of the humerus. The therapist moves the hand in the axilla laterally to distract the humerus. Ensure to be using proper body mechanics and pull your body into it. Distraction is sustained for a few seconds. You will first perform mobilizations in the cardinal planes and then move your way into quadrant mobes. The quadrant grade 2 or row the boat mobe is a quadrant mobe, which can address issues in more functional planes and motions. You will find where the patient's barrier is and then take them out of it, just short of that barrier. You will then position yourself so the patient's arm is hitting against your stomach, giving it a firm backstop, and then perform a large amplitude grade 2 mobe where you are bringing the patient's upper arm out and into your belly. You can do a smaller amplitude grade 1 mobe as well. By giving the patient your stomach as the barrier, it helps them to relax. You continue to do these motions until the patient's guarding subsides in bouts of 30 seconds. This is a great technique to modulate pain and is a great way to finish treatment. The video needed to be slowed down so I could ensure all my wording fits. This quadrant motion is a grade 3 or 4 and is called flop the fish. This is more used for stiffness when you want to increase range of motion. Use a pillow or towel to again provide a hard stop for the patient to know when the end of range will be. Again, you will see where the patient's barrier is and come out of the barrier just a little bit. The therapist should tuck their elbows at their side and ensure the motion is purely coming from their wrists into ulnar deviation. I am very stiff in my wrist, so it is quite difficult to achieve, but the motion should be purely coming from the wrists. As you bring your wrists into and out of ulnar deviation, the patient's arm will flop onto the towel in and upward and downward motions. You need to have the rhythm and find the sweet spot to create pain modulation and increase the patient's range of motion and decrease stiffness. The video needed to be slowed down so I can ensure all my words fit.